Okay, let's talk a little bit about gastritis. When we're looking at gastritis, I want to look at this picture. I want you to see that in the stomach area, you can't see very good, but you can see there's these little lines in the stomach, and these are called ruga, and they are really important in the stomach. The stomach lining is just a different type of a lining, and it's helpful for, some absorption and things like that. But when we get too much inflammation in the stomach, which could be because of some of the foods we're eating, could be because of stress even, then what happens is that inflammation in the stomach can work its way through this nice lining and cause what's called a sore or an ulcer or maybe even a bleed. But remember, gastritis is inflammation. And so we worry about a bleed with that. And there are two types of gastritis. One would be an acute type, which is about maybe you've had it less than 3 months, or chronic, which would be more than that. And so really pay attention to the different types, right? So if you have it for less than 3 months, you may have some epigastric pain, you may have some indigestion, you may have some anorexia, just means you're not eating. Weird hiccups, right? You may have some hiccups. Nausea, vomiting, bleeding. It says hemoptysis or hematasis, and then melena, which just means bleeding, either black tarry stool where you're having come out through the stool because you're having some type of blood coming from the stomach. It's taking a while to work its way through the intestine, or hematusia, which is bright red in the stool. So be aware, bleeding is a possibility. Let me explain this. Anytime there's inflammation in the body, it weakens the tissue. Okay, so if we have inflammation in the stomach, it weakens the tissue in the stomach. If we have inflammation in the colon, it weakens the tissue in the colon. So our chances of bleeding are pretty high. Okay, so this says no NSAIDs, which is probably an important thing to remember, because if you remember from one of the other videos, I said NSAIDs contain a little bit of aspirin in them. And so if you'll remember, aspirin can cause a GI bleed, so absolutely no NSAIDs for gastritis. The chronic signs and symptoms is a little bit different. And look, you get a little tired, some pyrosis, which is some burning, belching. I know this is going to sound crazy, but there was one man who brought his wife into the GI office because she was burping too much. And so that is more of a chronic gastritis. And then the patients will tend to have a sour taste in their mouth. And early satiety means that they feel fuller faster. Okay. And then maybe not want to eat, and maybe some nausea and vomiting. Maybe they can't eat a lot of spicy foods. But here's the thing. It says pain may be relieved by eating just a few bites. Big thing I think is important is that it decreases B12. Now, here is the thing about B12 and the stomach. You have intrinsic factor inside of your stomach. When you eat food, that intrinsic factor's job is to go and grab that B12, pull it all the way through the small intestine until it gets to that little ileocecal valve that I talked about earlier, and then it pushes it into the body. So what happens is when you get gastritis, you lose some of that intrinsic factor, which then decreases the amount of B12 that your body can absorb. So your B12 will go down. Anything that affects the stomach, as far as inflammation, or even stomach surgery, we had some of your stomach removed, can get rid of some of that intrinsic factor. So that's really an important thing to look about, the B12. Some of the interventions, what can you do if you have gastritis? Well, anxiety can cause inflammation in the stomach. Nutrition, the way we eat. I mean, if we're having a lot of alcohol, caffeine, acidic carbon drinks, salty foods, then chances are we're probably not going to have the best nutrition. Promoting fluid balance, dehydration increases bun and creatinine. Its creatinine will stay the same, but remember we need to be hydrated. Relieving pain, small frequent meals, no spicy, only bland foods. Now, what can you do to treat this? Now, I want to mention, you guys know for like GERD and usually a lot of stomach acid issues, PPIs and H2 blockers are the go-to, right? But you also now may have this little sore or this red area, which can then erode through the tissue, and you might want to coat it. I always say sucralfate is like a Band-Aid for the stomach, and you must take it before you eat. And so what it will do is it will coat the stomach, and this is a board's question, sucralfate or carafate. You have to know what that is. It coats the stomach. It's a little protective barrier. You can also add PPIs or H2 blocker. They do decrease gastric acid. The PPIs shut the pump off, right? And the H2 blockers decrease the amount of histamine that's produced in the stomach, which then decreases the amount of acid. So let's go. We've gone to your book for gastritis, and it says it's an inflammation of the gastric mucosa is one of the most common problems affecting the stomach. So, you know what? If you think you might have that, it could be acute or chronic. We would want to look at the difference between those, like I said. And then it says gastritis occurs as a result of the breakdown in the normal gastric mucosal barrier. So it's because of the inflammation, that normal, nice mucosal barrier kind of erodes. This mucosal barrier normally protects the stomach tissue from that stomach acid and pepsin. When the barrier is broken, it says then the acid and that pepsin can infuse into the tissue. This back diffusion results in tissue edema, disruption of capillary walls, a loss of plasma, and could even cause a hemorrhage. So I would just know what that is. Look at the causes. Let's just see if there's anything our patient would be on that could cause this, right? Aspirin. Remember, you should have no NSAIDs, no aspirin. Biophosphonates, corticosteroids. So if your patient is on long-term steroids, maybe for asthma, maybe for whatever, it can cause gastritis. Dig can cause gastritis. Iron supplements are hard on the stomach and the GI tract. And NSAIDs. There you go. Now, let's look at the diet, because you always have to know what diet. Alcohol, large amounts of spicy, irritating foods will irritate this. And the big thing, one thing that you really got to look at is H. pylori. H. pylori is a little bacteria that gets into the stomach and it can wreak havoc. So be aware this H. pylori, it exists, and most patients will have to treat H. pylori. But there's some environmental factors here. I mean, there's other things, microorganisms that can cause it, but H. pylori is the one that the boards want you to know. Radiation, smoking, look. Now, I want you to pay attention here. This is something you'll need for level 4, but a burn patient can start to have gastritis, or they can have peptic ulcers. And look at the other things here that can happen, diseases and disorders. So we're probably going to do an endoscopic procedure on this patient and go down and look at the patient and see what's going on. Okay, so we already know about the drugs. We know different kinds of drugs. We know about diet, spicy foods, right? We know, and let's look at H. pylori here. A key cause of chronic gastritis is H. pylori infection. H. pylori infection causes acute gastritis in most infected persons, and chronic gastritis may develop in some. Prolonged inflammation leads to functional changes in the stomach and may cause some stomach cancer. So can chronic gastritis lead to stomach cancer? Yes, it can. So just be aware that when we're thinking of these things, we have to think, okay, chronic gastritis could lead to something more serious. And we also have to look at the H. pylori, what is causing it. So if the doctor goes down into the stomach and he sees gastritis in the stomach, he's going to snip a piece of tissue and he's going to try to figure out what is causing this inflammation. in the stomach. Is it a bacteria? Is it a virus? Is it a fungus? Or is it H. pylori? Now, one of the things I want to tell you is for years, my husband complained of those chronic gastritis symptoms. And I told him, you're going to get an EGD. As soon as we went down with the scope, it showed, you could see he had H. pylori. It makes uh, a certain look to the stomach. So I found a picture that shows a little bit of what you see. Do you see how it has this little design here? When you go down with the scope, H. pylori is visible. You can kind of see it. There's other ways to test for it beside the scope, but you can see how red this mucosa is, and then you can see that there is some H. pylori here. When you look over at this, you can definitely see that there is, this is some gastric cancer. It looks different than you would see, and you can see some erosion here. So, can H. pylori or can gastritis with H. pylori lead to gastric cancer? Yes, it can. You can see that acute gastritis, look, here's the signs and symptoms. That's why I said do acute and chronic. And look, anorexia, nausea, vomiting, epigastric tenderness, feeling of fullness. Hemorrhage is often associated with alcohol use at times and is the only symptom. Acute gastritis is usually self-limiting, lasting a few hours to a few days. So you can get acute gastritis. But the manifestations of chronic are a lot more serious, right? And look, it says the source of intrinsic factor is also lost, which is it's essential for cobalamin, which is vitamin B, to be absorbed. And if you don't have that, you could develop something called pernicious anemia. So, wow, there's just so many things that can happen. This is just not inflammation in the stomach. Look at this. I want to mention that if the doctor, say for instance, the doctor suspects H. pylori, but maybe he doesn't, maybe someone doesn't want to scope, they can do a breath test. And what they do is they come in without eating or drinking for about an hour, and they have these two little bags, and the first one is blue, and they blow in it, and then they cap it off, and then we mix them a little drink of like a little, oh, it looks like a little orange drink. And what it does is they drink that down, then we wait a few minutes, and then we have them blow in the other bag. And by drinking that little acidic drink, if there's H. pylori, they'll blow carbon into that second bag, more carbon. We hook them to a machine, and it will tell us if they think that they have H. pylori. So a breath, a urine, a serum, a stool, you can do a gastric biopsy when you go in to look for H. pylori. But you can see it looks different, so you can see it. And chances are you might be a little anemic also. There's so many things to check for with this, gastritis. But just remember, gastritis, you're going to know acute versus chronic. You really want to watch that decrease in B12 and what not to have, right? Make sure you know that. And then just make sure you know how you can treat it. Now, we could lead into something called a peptic ulcer disease. Because of gastritis, it's going to wear down that lining. And so you could have ulcers. And when you have an ulcer, there's a couple things that we need to worry about with peptic ulcer. There's something called a gastric ulcer, which is actually in the stomach itself. And then there's something called a duodenal ulcer. And if you remember, I said it's in the duodenum, right? So if we look here, I like this picture, so I'm going to zoom in. You can see that a gastric ulcer is a big opening into the stomach lining. Now, here's the problem. If you have a lot of stomach acid, which you do in your stomach, and you have a sore or that tissue is no longer viable, then that stomach acid will eat through it like the speed of light. You remember your stomach acid is like battery acid, and it will eat through the layers of the tissue, and then you might just have a hole into your peritoneal cavity. Maybe peritonitis. Super important to remember. So anytime there's a peptic ulcer, we're really concerned. And then look at the little ulcer here in the duodenum. Remember I said in this duodenal area, 90% of your iron is absorbed into your body. So we really got to know what we're looking at when we're looking at these peptic ulcers. If you look, there's a difference in the way they present. If you have a gastric ulcer, it's dull, gnawing pain, sometimes radiates to the back. You might have burning sensation mid-epigastric. Immediately after eating, you might feel this. You might have some burning, which is pyrosis, vomiting, undigested food, constipation, diarrhea, bleeding, maybe even sour burping. Then we look over here to this duodenal ulcer, and the pain is different. Okay, pay attention to the differences in that. Pain occurs about 2 to 3 hours after eating. Now this one happens immediately after eating. There's more pain at night. Relief of pain after eating and antacid. Patient may pop antacids frequently. Pyrosis or burning, vomiting, constipation, diarrhea. And maybe even some black tarry stool in both of these. So pay attention to when the pain is. You'll have patients who will tell you, gosh, it hurts after I eat, but for about 2 to 3 hours after I eat, right? So the doctor's thinking, okay, that could probably be a duodenal ulcer. We are 100% worried about perforation, right? How would we know that this is perforated? Well, you're going to see bleeding. You're going to see the signs of bleeding in your vitals. Your heart rate will go up. Your blood pressure will go down. You might even get some severe sharp abdominal pain. You probably will. And it deviates over to the right shoulder. And one time somebody asked me, well, why does it deviate to the right shoulder? It's because of the phrenic nerve in the diaphragm. And when you have pressure in the peritoneal cavity, it'll push up on that nerve and it will usually send pain to the right shoulder, which is pretty interesting. We worry about hemorrhage, vomiting, large amounts of blood. You got to go to the ER. Stool blood is probably more of a smaller bleed. But if we look here, I like this a little picture. And if you see it says gastric ulcers, common risk factors, I would say H. pylori, look, alcohol, smoking, gastritis. Gastritis is a common factor for an ulcer, and it's also a common factor for gastric cancer. Most common well-nourished pain 2 to 3 hours after eating, or 2 to 3 hours after meals. Food may decrease the pain in a duodenal ulcer. And then gastric ulcers, know the difference there. Know the difference between these. Now, if you look, I'm just going to mention something that is a board's question, and I don't know if your instructor will mention it or not, but stress on the body, okay? When your patient is in the hospital and they have a brain injury, can they get a stomach ulcer? Yes, it's called a Cushing's ulcer. So a brain injury can cause stress on the body and cause a Cushing's ulcer. If your patient's in the hospital for burns, like if you worked on a burn unit, the patient could develop a Curling's ulcer. Shock can cause an ulcer. I mean, all sorts of things. So just know that stress, physical stress on the body when your patient's in the hospital can cause this also. That's probably why we put a patient on a PPI, right, in the hospital. So be aware. Let's see what we're going to teach the patient. Smoke cessation, dietary modification, watch for hemorrhage, right? The signs and symptoms of a hemorrhage. Look for blood in the stool, either bright red or black and tarry. Perforation, what's your blood pressure, what's your heart rate going to look like? Your temperature might even rise there. And then radial pulses weak, severe abdominal pain. Remember this, rigid board-like abdomen is a perforation. That's 100% a perforation. And then they'll have pain referring to the right shoulder because of that phrenic nerve, okay? Signs and symptoms of gastric outlet obstruction, nausea, vomiting, distended abdomen. What they're saying here is sometimes the gastric outlet, this little area, like this pyloric sphincter, can get obstructed, and then food can't make its way down in there. Some people do get an ulcer right there on that outlet. So no extreme temperature or food, hot or cold, and then no oral steroids. A lot of times people say, oh, give them a steroid, reduces inflammation. Not in this case. they will cause more of a bleed. They'll act like an NSAID. Okay, so let's look at the farm treatments. Definitely got to have antibiotics. Okay, for the H. pylori. Remember, when you have H. pylori, and this is one thing I learned in the real world, is there's like 700 ways to treat H. pylori. It's just crazy. But the probably the best first way is 2 antibiotics and 1 PPI. Okay. And so remember, she's going to ask you like antibiotics, metronidazole, amoxicillin, or clarithromycin, amoxicillin. Those are the 2 antibiotics. I think it's amoxicillin and clarithromycin. And we want them to take those plus a proton pump inhibitor, and they have to do it for 6 to 8 weeks to hopefully get rid of it. A lot of them will come back. They still have it, so we have to try maybe a triple therapy, or we might have to try a quadruple therapy, because there's 700 types of H. pylori, and it is a very hard bug to treat. So you just have to know that H. pylori can lead to peptic ulcer, right? It can lead to gastric cancer. It can lead to all sorts of things. So you really want to get rid of it. So amoxicillin, clarithromycin, metronidazole is also okay, but I think your instructor wants amoxicillin, clarithromycin, and then your proton pump inhibitors, or even an H2 blocker. But you have to get rid of the acid in the stomach so that we can get to the bacteria, and then we have to treat the bacteria with those 2 antibiotics. Now, if you did triple therapy, that's more clarithromycin plus amoxicillin or metronidazole for 10 to 14 days, plus a PPI. And then the quadruple therapy. So make sure you know, I'm not sure, whatever one she wants you to know, the triple therapy is a good one too. Quadruple therapy, they might add like Pepto-Bismol, bismuth salt, subsalicylate, which does contain a little bit of aspirin, but I'm going to say probably last resort. So just know your pharmacological treatment for this gastric or peptic ulcer disease. So if we had to go back over this really quickly, let's just kind of sum it up. Gastritis is inflammation and a lot more, right, in the stomach. It could be caused by a lot of things, but we have to know the difference between acute versus chronic. We also have to know, don't give the patient NSAIDs. Watch for their decrease in B12, because they're going to miss some of that intrinsic factor. We want to know what to do to treat, okay? Remember, you can coat the stomach. The little sucralfate is a Band-Aid, and then a PPI, an H2 blocker. But with ulcer disease, we really have to treat it. There's no question that we've got to do something. And so we got to know the difference between the gastric and the duodenal ulcer. We got to watch for hemorrhage. We got to watch for perforation. We have to teach the patient about what does a hemorrhage look like, what does perforation look like, what drugs are we going to put them on. Make sure that those are things that you look at in your book. I hope this is helpful to understand this, and we'll talk to you in the next video.